Okay, so welcome back everyone to this TAPAS closing event. We will, for now at least, skip the presentation of Abdesalim, and we will move to our second part on pathological speech assessment and treatment. And I'm happy to present you Dr. Timothy Pomé, who's going to talk about acoustic analysis of speech dimensions in pathological speech. Please, Timothy.
Thank you. So, yeah, for those who don't know me, I'm Tim. I'm a speech pathologist and also, as you just said, now a doctor, thanks to TAPAS. So I'll be presenting, so I'll be talking about acoustic analysis of speech today. I will not go into detail about my thesis. I'll talk about some things that we need to keep in mind when we do acoustic analysis of speech. Very briefly about my PhD. So I did my PhD in Toulouse at the Computer Science Research Institute with Julien Pinquier, Virginie Voisard, and Julie Mauclair. It was about intelligibility measures. And when people ask me about my experience, my PhD and my experience with the TAPAS project, one thing that really well, first of all, I'm really happy that I had that opportunity. And one thing that we had a lot was, well, before COVID, the mobility and networking opportunities. On one of these opportunities, I went to California, where I met another PhD from Canada. And I also met Jana Yunsova there, who was presenting a poster with a student. And 2 years later, I'm in Toronto, starting my own postdoc. And that's also thanks to TAPAS, so thank you very much for that. Yeah, so that's me now. I'm in Toronto for at least 2 years. I also did a very short postdoc in Liège with Dominique Morsom. Enough about me. So I'm going to talk about speech production, speech disorders, and speech assessment, especially speech, well, acoustic analysis of speech. So speech is one of the most complex and rapid motor behaviors that needs the coordination of lots of muscles at 4 different levels. So we have respiration, we have phonation, resonation, and articulation. And one thing that we know is that even in healthy speech, we have a lot of variability. So when we that's the first thing that we need to keep in mind when we look at speech disorders, because speech disorders, sorry, I have one, are also very variable. You have the etiology that can be very different. So you have neurological disorders, you have oncology, you can have hearing impairments, as we heard before. We can have speech disorders after trauma or surgery. So lots of different etiologies. The patients have very different impairments based on what structures are affected, the severity of the impairments, but also how they cope with that, how they compensate. So we have this additional variability that comes, that superimposes to the already inherent variability of speech in healthy speech. And so in clinical practice, we really need to have tools that are valid, reliable, comprehensive, feasible, so there are lots of conditions that we want to have to be able to determine the overall degree of the severity of the impairment, to target the goals of the therapy, and to see if the therapy is efficient and also if the pathology is progressing. And in research to get closer to these goals, we have lots of different aims and research questions that are addressed. Some of these are, for example, to identify the most relevant speech measures, understand the behavior of speech measures, even in healthy speech, as I said, which is already very variable, and to understand how these measures behave between patients or even for one patient from one time to another. So we have various things that we can assess or rate on each of these different levels. I'm not going to go into detail about all of them, but one thing that we know, well, what we notice is that today in the clinics, we mostly do it perceptually. So we listen to the patient and we try to assess what we see, what we hear. So that's in one of our studies, yeah, that's what we we target it. So we see that it is an issue because we as a human rater, we're subjective, and we will have the inter-rater variability. That means that I will not have the same assessment of a patient than you would have. And if I assess a patient now and I assess him in a month, I will not have the same rating based on my familiarity with the patient or my mental availability at that time. So we really need more objective tools to assess speech in our patients. And that's also something that we gathered from, so we did a study where we asked speech therapists what were the shortcomings and the needs in their clinical practice. And the need for more objective tools is also something that pops out. So I want to talk a bit about that, that term, objectivity, because I think it's something that's used very often as a binary term. And I think we need to see objectivity on a continuum. So a measure is not objective or subjective. It will be more objective than something else, but it's rarely purely objective. So we need to keep in mind that whatever measure we choose, there's always a bias. I will choose a measure based on the theoretical framework. I will choose where I will measure, where I will extract that measure. I will choose how I record the patient. I will choose what instructions I give him. So even when you say you use objective measures, always keep in mind that you're still a human being that's choosing who's making decisions. And so there's always some kind of subjectivity that stays. So when we talk about objectivity, I think the one term that's that we are targeting was that it's the reproducibility. So provided there is standardization, so we always make the same choice when we do the follow-up measures, for example, then we can say, okay, the measure is reproducible. It's not objective, but it's reproducible. I'm sorry. There are lots of things that we need to keep in mind when we're doing acoustic analysis in speech. One of which is that we try to capture something at one instant that is a phenomenon that is really very variable in time. So we have the long-term variability, which is, for example, I see a patient now, I see him in a month. Of course, the speech will have changed, but also the medium term that I would say, for example, if I see a patient in a session, I see him in the beginning of the session, I do a measure. I see him at the end of the session, I'll do the same measure. The speech will not be the same. The patient is either tired or warmed up, so both can happen. And even in short-term variability, for example, if you take the vowel A that's here, I take a window at the beginning or at the middle beginning, and I take a window a bit later. The measure that I will get from that is not the same. So again, that's a choice I make. Where do I take my measure? I also need to decide if I do I want to analyze the voice, for example, on a sustained vowel, or do I want to use continuous speech? The sustained vowel is easier to analyze. It's also, you can say that it's a more pure phonation, but then on the other hand, it's not really representative of the patient's speech in a day-to-day basis. And if I choose a vowel, which vowel do I choose? Do I only analyze the middle portion of it? Do I also integrate the on and offset of the voice? If I take continuous speech, do I ask my patient to read a text, or do I just ask him a question and try to elicit some spontaneous speech? These are all questions and decisions, again, that will have an impact on the measure. And we also need to keep in mind that if I take continuous speech, for example, and I want to do measures on a phoneme, for example, I need to keep in mind that the co-articulation effect, so the phonemes that are around that phoneme, will affect the measure on the target phoneme. Also, we need to keep in mind that the measures that we take, we need to ask ourselves, what am I measuring? How can I interpret that measure? Is there a meaning to it? For example, there are lots of measures that we actually use on a day-to-day basis, but we don't exactly know what it represents on a perceptual aspect. So for example, if I take the jitter measure, which is a measure of said as to be a measure that's of vocal fold vibration stability. Some authors say it's a correlate of breathy voice, and some say it's a correlate of rough or hoarse voice. So there is no consensus on the interpretation on acoustic measures today. And even if you take authors that try to build indexes so that use various acoustic measures to represent a more complex concept. For example, voice quality, you have several indexes existing today that say that, well, that are supposed to measure acoustic voice quality. But if you look at it, they don't use the same measures. It's based on various theoretical frameworks. So they're not measuring the same reality. So you always have to keep in mind, so what is this measuring, and what do the authors have in mind when they build that measure or that index, and how can I use it? So for each of the levels of speech production, you can have lots of acoustic measures in literature. I'm not going to go into detail about that. But basically, yeah, there's lots of speech research and authors trying to correlate perceptual and acoustic analysis, but there are still lots of things that we need to figure out. For example, for more functional concepts, more complex concepts, can we, and if we can, how can we predict, for example, more quality, speech-related quality of life, which is a very, very broad concept. This is a discussion that I had also during my PhD, and that I really think is important to address. What is healthy speech? So we usually, when you look at the literature, lots of authors presume that the control group, for example, has a perfect speech intelligibility. So you don't do the perceptual assessment on them. You say it's 100%. Whereas if you do the perceptual assessment, well, you notice that it's not, because you have that speech variability. You have these imperfections that we all have in our speech. And so we need to keep in mind that even if we use healthy speech as a gold standard, we need to know that there still needs, so if you use a norm, you still needs to use a measure of dispersion around that norm. And sometimes it's, instead of using norms, it's better to use a baseline. So you compare a patient to himself. So you do a measure from a patient, and then you compare him to himself and not to a norm. Sometimes it makes more sense. The gold standard is a term that historically is a so basically it's a monetary standard. So they used to compare a unit. It was a unit, so it was a standard of gold, so a quantity that's compared to a specific quantity of gold as a unit. So we should not see it as a noun. So it's not we should see it as a noun, not an adjective. So it's not the standard that is golden. It's the standard of gold, because the standard is not golden, it's not perfect. And that's something we need to consider when we look at our data. Something that we are still working on is to identify combinations of acoustic measures that could account for speech quality or voice quality or whatever. And we need to consider the different levels, so phonation, respiration, resonation, and articulation. But we also need to consider the different domains, so time domain, frequency domain, and capstone domain measures. And there are so many questions that we need to address. And yeah, I think that's we shouldn't see that as something we learn in our PhDs. It's not a problem. It's just a challenge. So when you do acoustic measures, of course, you have to check for validity and reliability. That's classics. But you also have to consider the age and gender effects. You have to see the co-articulation effects. You have to see, well, as I said, how can we interpret these measures? Can we set pathological thresholds? Do these measures respond to change and lots of things like that. And one of the shortcomings in the literature nowadays is consonant measures. When you look at the literature, there are lots of things on vowels. There are lots of studies on consonants, but mostly in the time domain and not in the frequency domain. So that's something that we need to investigate a bit more. And we did it in my PhD. We did the spectral moment analysis, for example. And then I think that, well, I'm not going to talk a lot about automatic analysis. I think my colleagues are way better in that. But I think that one of the issues that we ran into during my PhD was that, for example, the forced alignment today works better and better. It gets better. It improves in pathological speech. But if we want to consider spontaneous speech, so text-independent segmentation, yeah, it gets tricky, really tricky. So that's something that needs to improve if we want to have more functional assessments. And also then the questions that get more complex, like what about the functional impact of the speech disorder, or the impact on the quality of life, which comprises lots of factors that we need to keep in mind. And yeah, for that, I think deep learning techniques are amazing tools that will help answer some of the questions, I hope. A last thing that I want to stress is always keep the clinicians in mind when you do your studies. So clinicians are usually a bit overwhelmed when we talk about acoustics and deep learning and stuff like that. But they don't need to be. I mean, if you can explain it to them in an understandable way, lots of them will be pretty excited to participate and to test the tools. And but you really need to get to them, speak to them, and don't start doing your study and then go to them and just to fine-tune your stuff. Go to them in the beginning and then see what's the need, how can we help, and how can we collaborate? Because you have lots of things that you can offer them, but they also have lots of things that they can offer you. And if you don't do that, the risk is that we're doing amazing things in the whole TAPAS project. But if I fear that at some point, lots of these things will just get lost because they will not get used because that contact is missing, actually. And always keep in mind, well, ask yourself, what am I doing and how can it be used? If you investigate acoustic measures, for example, can the clinician actually use it? If you're in the clinical application field, of course, can the clinician actually do something with that? Or is it just going to give him a score? And then, yeah, he has a patient, he has a score, and then what do I do with that? And the dream would be to have a visual tool that the clinician can use to clinically interpret the acoustic data. And yeah, that's a challenge to all of us, I think. And that's it. Thank you.
Okay, thank you, Tim, for all your perspectives and insights in this topic. Any questions or remarks? Any questions online?
I have a question, if I may.
Yes, please.
Okay, thank you very much for your presentation. Very interesting. I actually have a question regarding the last part. You mentioned you don't give a clinician a score. So what do you actually mean? Because for me, I find, and now that I'm working in the clinic closer to the clinicians, I find it quite hard to give something to them that they will use, because exactly this problem. So if I give them a score, I just tell them if it's high is good, if it's low is bad, and that's it. So they don't have to think about too much about it. So what do you mean when you say you don't have to come up with just this thing?
I think the score is something that's interesting if you want to detect something, but the thing is that usually clinicians, like a general score is useful because it's reproducible, for example, if you do follow-up measures. But when you have your patient in front of you and you have that score, it says, yeah, the speech is not good. And the clinician will be just like, I know it. I know that. But how can I improve it? And so it would be that I think we need to get more specific into meaningful scores, and that's the problem with deep learning and the black box and stuff like that. Well, in my thesis, I didn't do deep learning. I looked at specific acoustic measures, and when I was doing that, I tried to see, for example, we use the spectral moments because it's four acoustic measures that are supposed to be acoustically interpretable, and supposedly you can infer the place of articulation, for example. And if we have that measure, that would be a score, but we can also visually show it, and it would say the clinician, for example, yeah, that's it's not good, but why is it not good? Like the point of articulation is too in front or too in the back, or for example, like that. So with deep learning, I honestly don't have an answer to that question. But if you look at specific acoustic measures, I would say when you choose your measures, try to choose measures that we know from the literature that have an articulatory interpretation, and that's pretty difficult to find though, because as I said, we don't agree on that. So we have some reference that say, yeah, for example, the center of gravity. Is it still working? Yeah. The center of gravity is supposed to represent how in front you are in your articulation, but again, that still needs to be proven. So yeah, I see that someone's not not agreeing already. Yeah. So yeah, I don't have a clear question on that, a clear answer on that. I'm sorry about that, but yeah.
No, it's okay. I just want to add something to that. I think we are, as clinicians, happy with objective scores, identifying the degree of deviation of a certain parameter like intelligibility or articulatory precision. But what we can also use in clinical practice is what our ears are not able to detect or are struggling with to detect. And then I'm talking about more detailed information. So like Timothy is pointing out, place of articulation, to which degree did the patient put the articulator in the place where it is expected to be. So that's, yeah, I think it's another level. And also for the patient, it's really useful to have that kind of feedback. So yes, Matthew wants to add something.
My question was coming along the same lines, because clinicians, they have their experience, and in the experience, how would you translate that experience which an engineer would understand to relate? So for me, this is one of the main questions, because they have experience and they are translating the experience. Look, this is what it is, and I know maybe at the beginning of their career there will be different, then later in the career they will have a different way of judging the pathology and the assessment and all. So how do you translate? So when we keep clinician in mind, as an engineer we give a score, but how do we translate to a clinician's view? How can we do? So how can we make that relevant? Is it easy, very difficult, or is there something more need to be done?
No, I think Matthew, you've got a good point. I think sometimes we do speak other languages and we do have a certain experience that I think it's often difficult to bring into words and to transfer to you. But from my point of view, and that's really the clinical point of view, I think that the algorithms should follow the definition of what we think that we have to measure and are measuring, and not the other way around. And I think that's sometimes a little bit tricky, that sometimes algorithms can, and especially I think with the deep learning, measure something, but are not always matching exactly what we are listening to or are thinking that we're listening to. That's important too, yes.
Thank you very much for a nice talk. I just want to add a little bit of perspective on that, because we, with our Cognospeak tool, is very much at that stage where we're trying to co-design with the clinicians what the assessment report should look like. And it's definitely not just one number. And I think it's a very iterative process. So we're thinking it will take a year. And the first thing we've had is a long list of things that are meaningful to them. And we can look through the list and we can probably provide most of these scores or ranges. But we're at the same time thinking, but we know those aren't the most important features for the classification. So in the background, we will probably be doing other things and perhaps also somehow presenting that. So I think it's a two-way thing, isn't it? Because if we don't present something useful, they're going to revert back to what they've always been doing and they're not going to trust at all. And I think the deep learning, the kind of all of the work done to try and make it more interpretable is really important for this.
Can I add something to that?
Timothy was already talking. Wait a moment.
Okay.
Sorry. Yeah, I'll let you speak. Sorry. Go on.
Okay, yeah, thank you very much. Yeah, these are very useful considerations, and I've been thinking about that a lot the last years. And of course, in general, we want to obtain features, parameters that are interpretable and useful for clinicians. That's one thing, yes. But on the other hand, of course, we should also try to explore new options. For instance, we often look at MFCCs, very difficult to interpret. But if we find interesting differences for MFCCs, we should try to interpret them, or maybe use other features that are related that can better be interpreted. So on the one hand, I think you should always co-design with clinicians for sure, and it's good to look at the things, the measures they have in mind. But I think it's also useful to explore other, let's say, more technical measures, because they can be promising in the future.
Yeah, thank you. I agree on that. I think we also should make a difference between assessment and detection. For example, MFCCs, I would say, is more detection of pathology, and rather than really assessment of what's going wrong. That might be a tricky, dangerous pass here, but yeah. But again, I mean, well, I'm going to say it's Thomas. I'm not a computer scientist. I'm more of a clinician. But I think that's I'm saying that now, but the thing is that we should not be afraid of the language difference and the knowledge difference. Either a clinician or a computer scientist, it's two very different worlds, and we need to get together and just discuss things very openly without thinking, oh, I don't know that, I don't know what he's talking about. We'll just say it. I don't know what that is. What is MFCC, for example? And as you said, it's an iterative process. So you start, you get together, and then during the whole process, there are lots of things that you will not understand, that the other one will understand, and so it's a two-way thing. Yeah, as you said. Any other questions? Thank you.
Thank you, Timothy. And I really just want to add that I think this project shows that we can understand each other from time to time. Okay, let me stop sharing this one, stop recording.